Good afternoon, everyone. Thank you so much for coming in for this very exciting new session that we have since the past year called Translational Research Controversies. And really what this is about is discussing some controversies that we face in translational medicine and how do we address those controversies. This is not a debate. We're not trying to take a pro or a con stance. We have 3 interesting questions that we'll be addressing in this session, and we have fantastic faculty, 2 of which will be addressing 1 question. And so I think the idea here is how do we highlight what have we learned, what are the issues we face, how do we overcome them? And I'd love for you to have any questions you might have that bother you or seem to be an issue that you think we can address for you. There are going to be polling questions just to see what you think about it before the talks and after the talks, and if the talks helped you change your mind about these controversies. Would love for you to be engaged with that. Use your Slido, your QR code to actually be able to vote for these questions so we learn what we can understand about these controversial topics. So we have our first topic, which is Baby-TAM, and we're going to kick off with our first speaker, Dr. Perou from Karolinska Institute in Stockholm, Sweden. Thank you.
So, thank you very much. Thank you for inviting me and to be able to address one of my pet projects, or pet issues. That's low-dose tamoxifen. So my name is Perou. I'm a medical oncologist by training. I've done full-time research for the last 2 decades. My disclosures are that we collaborate with 2 companies, US companies. None of them are, though, involved in this study that I will reveal right now. Oh, there came a question.
So this is when you would use and join the slido.com so you can vote for the question.
Okay. Should I continue?
Yes.
Thank you. So a very, very short history of tamoxifen. So in 1978, it was approved by FDA for therapy for breast cancer. You all know about that. 20 years later, tamoxifen was approved for prevention. And as Jack Cuzick described in the Macquarie lecture 2 days ago, 5 years on tamoxifen has a protective effect for the coming 15 years for women, which is quite amazing. However, there is a challenge, and these are the side effects of tamoxifen, well-known menopausal-like symptoms. So we started thinking, could we do something about this? And the question was, would lower doses of tamoxifen have the same effect as the established 20 milligram dose? Could we identify lower doses? That was the issue. So this is a dose determination study. If you want to do a study in the old-fashioned way, where you randomize a lot of women, follow them for 5 years, see how many cancers they develop, then you need probably 100,000 women because there's small differences between the doses. So what we did as an outcome was instead density change. So here you see on the left-hand side, you see a mammogram before exposure to tamoxifen. Here you see after 3 months, after 6 months. So we designed our study this way. So women were recruited from one of the larger hospitals in Sweden, where they screen approximately 80,000 women a year. They were randomized to 20, 10, 5, 2.5, 1 milligram, and placebo. We included 240 women in each arm, 1,440 altogether, and blood sampling and mammograms were taken at baseline and at exit. It was a non-inferiority design, so the question was, were low doses of tamoxifen non-inferior in its ability to reduce density compared to 20 milligrams? And we set the threshold as the median decrease of 20 milligrams. That's 10.1%. And remember that normally a woman decreased by 0.5 to 1% a year, so this is quite a profound decrease. We then looked for the proportion of women in each treatment arm that had the same density change as the response to it in the 20 milligram arm. So here, this is quite a busy figure, but nevertheless, you have dose on the left-hand side. You have the proportion of women, and as you could see for all women, you could see that women in the 10, 5, 2.5 milligram arm decreased. The proportion of women who decreased 10.1% were more or less the same. However, and the important take-home message, these results were completely confined to the premenopausal women. We didn't see anything in the postmenopausal women. Actually, the decrease for those on 20 milligrams and those on placebo were exactly the same. Why this is, we still don't know, because we do know that tamoxifen in the adjuvant setting could be used for postmenopausal women. Could it be that 6 months is a little bit too short time? We don't know. And the density change in the premenopausal women were 18.5, and in the postmenopausal women 4.0. So here are the severe side effects. We looked at hot flashes, cold sweats, night sweats. We could see here, again, all women. Here you see the premenopausal women. You can see that there's a definitely decrease, although not significant, in the 10 milligram arm. The reference is, of course, 20 milligram, but you can see that there is approximately 50% decrease in the 5 and 2.5 milligram arm. So the conclusion was that tamoxifen dose of 2.5 milligrams lowered mammographic density to the same extent as 20 milligrams. However, tamoxifen is a prodrug and more or less not particularly active. It's metabolized through the CYP2D6 gene, a very complex polymorphic gene, but you could sort of divide the polymer, the ability to metabolize tamoxifen into poor, intermediate, normal, and ultra-rapid. We choose to follow endoxifen because endoxifen is the metabolite with the strongest affinity to the estrogen receptor and also the highest plasma concentration. So this is then, I underline, only premenopausal women. On the y-axis, you have density change. Here's 0. Here is the dashed line, is the change that you see at 20 milligrams. On the x-axis, you have the plasma concentration of endoxifen in nanograms per milliliter. You see the blue dots, that's the point estimates of the different doses, 20, 10, and so forth. And as you could see, around 2 to 3 nanograms per milliliter, you actually have a decrease that reaches the decrease you see in 20 milligram. And the interesting thing is you can't see any further decrease as concentration increases. So the next question, and one of the last slides, is what do we need? What tamoxifen dose is modified by the metabolite status? So here again, poor, intermediate, normal, ultra-rapid. You have the proportion of women that are poor, 6%, approximately 40%, 50% approximately, and very few ultra-rapid. The blue is, again, endoxifen concentrations, nanograms per milliliter, and the blue figures, you can see that they are way under 2 and 3. But for the intermediate and normal, these are the most interesting because they consist of 90% of the women. There you see, you reach 2.4, 2.7. Oh, sorry. Oh, that's. No. So you reach 2.4. And the threshold that we talk about. And you can also see that 20 milligrams gives quite high concentrations. So then, of course, you could ask yourself, why don't we give endoxifen directly? So we're actually conducting a trial now, the Charisma endoxifen trial, where we randomize 240 women into 3 arms, 80, 80, 80. 2 milligrams is a little bit more, equivalent, a little bit more than 20 milligrams of tamoxifen, 1 milligram a little bit less. And here you have we have ended recruitment a month ago. And we are looking forward to the results after next summer. So, take-home messages, 2.5, 5, and 10 milligrams of tamoxifen lowers density to the same extent as 20 milligrams. Severe side effects are reduced by 50% in 2.5 and 5 milligrams. It seems like endoxifen concentrations of 2 to 3 nanograms per milliliter lowers mammographic density to the same extent as 20 milligrams. And for intermediate and normal metabolizers, that's approximately 90% of the women, it could be that 5 milligrams is enough. But I would like to send you this message. I want to underline that this is a study where we didn't include patients. It's a prevention trial. We didn't use breast cancer incidence or recurrence as the outcome. We used density change. So we should be a little careful when we use these results. Yes, quickly, these are the people that helped us in the study. And if you want to have more information about us, you'll find that there. So,
thank you, Dr. Hall.
So it's going to be
together. We'll take the questions together after we have Dr. Cuzick. And he's going to talk about Baby-TAM as well. Let's see what he has to say. He's from the Queen Mary University of London. Thank you so much.
Thank you very much. So I'm going to carry on a little bit with what Per's done and talk a little bit about some of the studies. Really, Professor Andrei Zhechensky should really be giving these talks, because I'm going to really talk about his work primarily, but looking at not only the effects on biomarkers, but the effects on disease. So there's the Slido thing. I guess I don't know what you're supposed to do about that, but there it is.
They're going to take the picture of the QR code so that they can vote.
Okay, fair enough.
There you go. That's the question now.
Okay.
So if you
So
could
the
please
question
vote.
is, should we consider taking Baby-TAM at all? And you're asked to give a yes/no answer to that. Is this worth even considering? So just a yes/no.
Look at that. We have a unanimous vote here.
And everybody says yes. That's the right answer, I think. Okay, great. Okay, so I want to talk a little bit about, again, most of this talk is going to be about just some of the stuff that's been going on with the Italian group. They set up the TAM-01 study, which was basically, they took women under 75, 3 years of treatment with either 5 milligrams, 1/4 of the dose per day, or placebo, and followed up ultimately now for 10 years. Now, they published a while ago the 5-year follow-up, but they've now recently just published their 10-year follow-up data on this study. And it's a randomized trial where the endpoints are invasive breast cancer, either DCIS or invasive breast cancer. And so 500 women in this study in 14 centers across Italy. And so here's the primary results with now 10 years of follow-up is a continued benefit, 3 years of treatment, as you can see, and the number of breast cancer events, that is DCIS or invasive cancer, were reduced from 41 to 26. That's highly significant, p equal 0.028, a reduction of about 40% altogether, has a ratio of 0.58. So not only is this a biomarker study, but it actually shows that if you randomize these women, you can actually reduce this. Now, one of the challenges in this study is that it was a low dose versus nothing. And the reason for that partly was that the women were recruited mostly because they didn't want to take tamoxifen at the standard dose. So that wasn't included, but they were willing to take it at the low dose or not take it at all. So that's why this focus doesn't have an arm on standard dose tamoxifen. Virtually no adverse events in this study, nothing significant. The only thing that shows up at all is endometrial polyps shows up 20 versus 13, and other cancers again were higher on Baby-TAM than placebo for reasons that are again not significant and probably not relevant. So recently they've actually got a grant now with Breast Cancer Research Foundation for a study they call Baby-TEARS, and it's going to be a combination. Sorry, the slide's not absolutely perfect, but it's basically going to be a randomization of baby tamoxifen, 10 milligrams per day, versus baby exemestane at 25 milligrams per day. Exemestane is given; these are both given 3 times a week, so they're not given there's going to be every and it's going to be. This will be a short-term biomarker study looking at 20 months of treatment, 12 months of treatment in these two particular groups. And they've recently published just a look at what happens with the lower exemestane dose in terms of estradiol levels. They looked at it 25 milligrams daily, 25 milligrams 3 times a week, 20 milligrams once a week, 25 milligrams once a week. And you can see that the 25 milligrams 3 times a week gave effectively complete suppression of estradiol, just as the daily dose did, about a 98% reduction. But if you went down to just once a week with 25 milligrams, there was still not nearly such a complete reduction in estradiol levels. So that's led them to consider that the next study they're going to go forward with is going to be that comparison of 25 milligrams 3 times a week versus tamoxifen at 10 milligrams. Well, so I want to finish now and talk a little bit about some of the things that I think are new that really need looking at as well. And this is stuff coming from the IBIS-2 study, which I've said a bit before, which was essentially a trial of almost 4,000 women given anastrozole for 5 years And one of the things that we did that turned out to be incredibly useful is we took baseline 1-year and 5-year blood samples. And we're just beginning to deal with those. You can see the overall effect is a 50% reduction over the 12-year follow-up that's been reported so far. And the results, again, I think I've shown these before, but I think they really are important here, is that, that in fact, the results are really quite interesting, and that is aromatase inhibitors work by stopping the production of estradiol. So interestingly, if you look in the placebo arm, you see that there's a reduction, the percentage of patients that got cancer should be equal, in these 4 quartiles, should be 25% in each of them. And in fact, in the placebo arm, there's this clear gradient, 15% in the lowest quartile, up to 30% in the highest quartile. So a clear reduction overall in that 0.0033. Whereas in the anastrozole arm, there was really no effect on estradiol. Well, there was no effect on the different quartiles of estradiol in terms of the amount of cancer. It was virtually constant. So in fact, the most important result was actually for the lowest quartile, where there was a very tiny reduction. You can see it was 18% of the relative benefit, compared to a 50% reduction overall. 50% reduction was achieved overall in this trial, and it's slightly bigger than that, in the mid-50s for the 3 higher quartiles. But at the lowest quartile, virtually nothing happens. There's not a significant reduction. And that's indicating if you start off with a low level of estradiol, you're not going to get rid of it because there's nothing really to get rid of. And that seems to indicate that, in fact, those patients gain nothing from this drug except the side effects, which is not really a gain. So a really interesting challenge is that I think we now need to more seriously think about measuring estradiol beforehand and titrating, giving treatment just to the patients that have something that you can actually protect. There's a huge amount of work to be done now to actually begin to do this. It's cheap to measure estradiol now. We've got cheap, good assays for about 25 pounds to do estradiol and testosterone. And there's a really good chance now, I think, to begin to look at maybe even more precisely than with tamoxifen, by looking at the changes in estradiol, can we actually determine what the right dose is for giving this drug, and is it likely to be personally chosen based on estradiol and maybe some other factors as well. Certainly it doesn't seem to be any point in giving it for those that have very low estradiol, but it may be for the other ones that you can actually begin to titrate the dose to minimize side effects and still achieve the benefits. So I think that's another area that's quite exciting, and thank you very much.
Thank you so much, Dr. Cuzick. So we have time for a few questions. Any questions for Dr. Hall or Dr. Cuzick? I see Dr. Carey running to the microphone. There you go.
Of course, they stuck the microphone in the way back. Jack Perou, there's a terrific presentation. Illuminate a little bit. One of the problems with full-dose tamoxifen or AIs is adherence, and many of our patients don't take the drugs as prescribed. Are there data in the Baby-TAM literature about how adherent patients are, and is it improved?
Is that for me? Because, yes.
Is there data on literature for adherence for Baby-TAM?
Okay, thank you very much. That's a good question. The problem with this study is that the women who participated in the study are really strong believers in they have an altruistic view on things, and many of them also have relatives that have had cancer. That's the selection. So we saw, and here we saw a dropout rate of 27%, which was absolutely the same all over all 6 groups actually. So I would say that from that perspective, it's really hard to extrapolate from our data.
Yeah, and just to say, in the detention trial, these were patients that refused or declined to take the full dose of tamoxifen, so there would have been very low compliance to that. But the compliance here was really very high. I've forgotten what the numbers are. But they were they chose to take low dose rather than standard dose as a personal decision.
Thank you. I had a question as well. So this is very exciting data for our prevention with baby tamoxifen, and sounds like with baby tears. I like the name, baby tears. We have many initiatives. We have the FDA with the Project Optimus, where we're trying to use optimized dosing rather than the full dosing for treatment of invasive breast cancer, metastatic breast cancer. We have patient-centered dosing initiatives also to try and optimize the right dose and balance those side effects and toxicity. Do you see a place for low-dose tamoxifen or low-dose aromatase inhibitors for invasive breast cancer, and how could we safely study that for invasive disease?
Well, if I can start, I think we should begin with prevention because, sorry, we should begin, is that better?
You need to push it, don't you?
Oh, okay. How's that? Yeah, all right. Okay. Sorry about that.
Thank you.
Sorry, you were asking about the.
You should begin with prevention.
Begin with prevention, actually, yes. And yeah, I think that there's a lot to be learned. I mean, it's quite conceivable that we will actually learn to titrate the dose of the aromatase inhibitor to bring the estradiol down to a specific level. That's conceivable. We haven't really begun to look at that, but it's quite possible that we can begin to think a little bit like the cardiologists who use who do titrate to bring down their drugs as necessary. And that's, I think, an option now. Now that we've got an ability to measure estradiol easily, we should think about looking at whether or not there is a specific dose that you should try level that you should try to choose the dose that achieves that.
So I think that you could start using 5 milligrams in a study, not to start 5 milligrams in the diabetic setting because the data is not there yet. But there are several studies around, definitely in Europe anyway, where you use low doses of tamoxifen. You follow patients either through density or endoxifen concentrations and or supertabulated status. So I think it's about time to launch the studies, but I wouldn't do it without studies.
Thank you. I also had one other question about the dosing for the baby tears study with tamoxifen at 10 milligrams. Was there a particular reason to choose 10 versus 5? Or what guided that decision?
I don't really understand it. And that was 10 milligrams 3 times a week.
I see. So even the tamoxifen dosing was 3 times a week,
yes,
like the
yes,
anastrozole.
yes. So they'll be, yeah, exactly. Yeah.
Interesting. Very interesting data. Thank you so much for sharing that.
Can I say something?
Yes, please.
Yeah, thank you. I'm Ann Fonfa from the Anti-Appleseed Project. I'm a patient advocate. Speaking for patients, I've been thinking a lot this week about Halstead. Everybody worshipped him and thought he was a brilliant genius, and we surged the heck out of people. So now, listening to cutting down on stuff, I am thrilled because lots of people are suffering from treatment and too much treatment. We really appreciate the idea of less. Thank you.
So over the next 20 minutes, we have the next 2 set of speakers, and the topic for them to cover is when would we do a window trial? So our very first speaker is Dr. Sara Hurvitz from Fred Hutchinson Cancer Center, University of Washington in Seattle, Washington.
Thank you, Komal and all, for inviting us to talk about this. So window of opportunity trials are a really exciting venue in which we can actually do interesting biomarker research, in vivo research on patients. And I'm going to talk about that after you do your Slido. So go ahead and get out your cameras, take a picture. And the question is, window of opportunity trials should be considered for drug development, yes or no?
This is a unanimous crowd.
We're preaching to the choir. Oh, a few no's are coming in.
Okay.
Give it 6 more seconds. All right. Okay, there we go. All right, so in a window of opportunity trial, drug is administered for a very short period of time, 2 to 3 weeks, in the time prior to surgery. This allows for tissue sampling at baseline before the tumor has received any exposure to a novel therapy, and allows in vivo testing of the novel therapy in a human model of real cancer. Now, there are different ways you can do a window trial. The first window trial I was involved in was a study that Rich Finn led when I was at UCLA, looking at a drug, I believe it was dasatinib, and patients signed up and willingly did what is shown in that first picture there, came in, had a biopsy, got 2 weeks of the study therapy and had a repeat biopsy, or went directly to surgery. There's a lot of controversy about doing this because the potential benefits to patient are quite small. It's unlikely they're going to derive benefit in that short period of time, unless the new therapy or another therapy like it is offered after surgery. In other iterations, you can do 14 to 21 days of the novel agent on each end with a biopsy for biomarkers, and then give standard therapy for a period of time prior to surgery, either with the new novel therapy to test how the two work together, getting more tissue at the time of surgery, or just doing the standard therapy after the novel agent. Now, actually, my colleague here, who will be speaking to you shortly, Professor Dowsett, is the father many would consider of window trials. He ran a study called Impact, which paved the way for these studies in hormone receptor positive breast cancer, because he showed that a Ki-67 change, the change in the marker of proliferation or cell division after only 14 days of endocrine therapy, actually was predictive of long-term outcome. So in this study, you can see each individual patient on the top is, on the top curve, marks one patient. If that patient is color-coded red, those are patients whose baseline Ki-67 reduced less than 50% at the time point of 2 weeks after receiving tamoxifen or anastrozole. And if they're in the green, their Ki-67 dropped more than 50% from baseline to 2 weeks and stayed down at the time of surgery with a less than or equal to 50% increase at 2 to 12 weeks. And then in the blue, these patients had their Ki-67 drop, but it rebounded by the time of surgery. And if you run the Kaplan-Meier curves of this, in the lower curve, you can see that only the green patients are doing really well. So because of that, a number of studies, including this one here, you will see come through modern studies of novel agents, many of them in hormonally targeted or hormonally driven breast cancers that tend to respond clinically slowly. So we're using this surrogate marker of change of Ki-67 to give us a snapshot of what might be happening later and provide data to go forward into larger adjuvant studies and also give you safety. So in NEO-Monarch, we gave patients in 3 cohorts either abemaciclib, the CDK4/6 inhibitor, abemaciclib with anastrozole, or only anastrozole for 2 weeks, and then everybody received both drugs at week 2 until the time of surgery. And on the right side, you can see the mean changes in Ki-67 for the 2 abemaciclib arms in that 2-week period substantially dropped, paving the way for more studies of this drug in the early stage setting. Another study that was recently published was Co-op-ERA, similar trial design, but now looking at an oral SERD versus anastrozole for the first 2 weeks, and then for the rest of the time after that 2-week time point, patients receive combined therapy. So this type of design is a little more exciting for patients to participate in because they're getting a novel agent and they're also getting standard therapy, which is known to be effective for breast cancer. And here are the data showing the change in Ki-67. On the left in red is the giredestrant, and on the right is anastrozole, showing the biological activity in terms of Ki-67 reduction is high with the oral SERD. So the advantages are they're short studies, quick readouts, small patient numbers, affordable. You can do pharmacodynamic evaluations, biomarker evaluations. You're not delaying curative curative intent therapy, and a meta-analysis indicated there's no effect on long-term overall survival by patient participation. But you have to keep in mind, patients aren't likely to benefit in a pure 2-week window study. Extra biopsies, safety profile may not be fully elucidated, and a paucity of validated surrogate biomarker endpoints. And endpoints are shown here, but I'm going to now, in the interest of time, turn this discussion over to my colleague, who's going to give you a much more in-depth viewpoint on this topic.
Thank you. So we now have Professor Mitchell Dowsett from Royal Marsden Hospital in London.
Thank you very much, and thank you to Sarah. You may have noticed we switched the order in this particular part of the session to allow Sarah to take you through more of the basic stuff, and I'm going to be dealing with some of the sort of more complicated issues that occur in certain circumstances. So I very quickly, in a somewhat staccato fashion, I'm going to take you through these 6 points. Looking at extended opportunities from window studies, we're talking about the estimation of prognosis when on patients on endocrine therapy, the relevance to prevention, and particularly relevant to some of the what we've just been discussing, and also some of the limitations, the importance of including controls, the relevance to non-endocrine agents. Again, Sarah's just been talking about CDK4/6 inhibitors there. The importance of thinking about the pharmacokinetics and particularly the pharmacodynamics. I'll talk about tamoxifen in premenopausal women, and then just talk about the relationship with some of the commercial molecular profiles that we have. So when we're looking at the benefit, the response to any agent, we're interested in this change in Ki-67. And that's what we've shown to be related to the benefit from aromatase inhibitors versus tamoxifen in the adjuvant setting. Clearly, in the baseline situation, we know that Ki-67 is prognostic, and many people actually measure it for its prognostic benefit. And we rationalized some time ago that if we measure the 2-week Ki-67, this would integrate the pre-treatment prognostic value with the impact on that to determine and relate to the prognosis on treatment, which you'd also call the residual risk of recurrence. And we went on to test that in the POETIC trial. I'll show that in a moment. But just to remind you, that's exactly what we're trying to do with the molecular profiling tests of Oncotype, Prosigna, breast cancer index. That is, to identify the prognosis of patients if they take endocrine therapy for 5 or more years now. And therefore, the 2-week Ki-67 value, in a way, is trying to do the same thing. So how well does it do it? We tested that in POETIC. I'm pleased that my colleague Ian Smith is in the audience. He led this trial. John Robertson and Judith Bliss were also co-PIs. And I think this is probably the biggest window study that's been conducted. 4,500 patients were randomized to an aromatase inhibitor or not in the 2 weeks before surgery. And we measured Ki-67 on both. There was a clinical endpoint here which actually determined the size of the trial. And we found that there was no difference in the clinical outcome of patients according to whether they had this peri-surgical treatment. However, we were really focused on the Ki-67 level, and we dichotomized it at the level of 10%. This seems to be particularly gaining traction as a value used in many studies. And low Ki-67 equates to less than or equal to 10%, high to greater than 10%. The patients that started low, and let's see if I can use this, yes, a pointer. Patients that started with values below 10%, not unexpectedly, had values lower than 10% in almost all cases, and they had very good outcome. However, those patients that had high Ki-67 to start with, the separation of those according to whether they had low or high Ki-67 in the 2-week sample. And you can see here the 5-year absolute risk there, 8.9% if they were high to low versus the high, 19.6, very high expected recurrence over those 5 years. Sorry, I thought I'd actually put something in there. It's obviously hidden behind the slide. one observation we made just over the last week or so, because I was thinking about this meeting, was how did this integrate with oncotype? We do have oncotype, pseudo-oncotype anyway, on several hundred of these patients. And the indication is that it is separating the intermediate group as to better and worse outcome according to whether they have Ki67 low or high. We need to do more work on that, and then hopefully in future we'll be able to show you that in a session like this. The other thing that I think, this is really quite controversial, an unusual way of thinking about things. The patients that present with breast cancer, 2 weeks, a month or so before that, they didn't think they had breast cancer. Yet these are the sorts of cancers, in the few years before presentation, that we are probably suppressing with our chemoprevention activities. And the biology of tumours in that period of a year or two before presentation are likely to reflect the biology of that tumour at presentation. And therefore, I think it's reasonable to rationalise that the biology that we probe with these agents in that perioperative therapy can indeed reflect the preventive activity. I think this is a really good opportunity for some of the answers from the previous session there about, well, could we test out lower doses of aromatase inhibitor, lower doses of tamoxifen in this particular scenario to evaluate their potential in prevention. In this situation, it's quite tempting, it's been done in some cases, to not have control groups, to not randomize against control or placebo, because you have two values on the same patient. Why do you need a control? Well, this gives you an indication of why that is. In the POETIC study, we found that in the control group, there was an overall 14.6% drop in Ki67 over those 2 weeks. It was actually very small in the patients who had a core cut taken, not just at diagnosis, but also at surgery, and much larger in those at core cut to excision. There's almost certainly some loss of proliferation during the time that that tumor is fixed, and it takes a long time, potentially up to 24 hours for fixation. This was even more extreme when we did this little study looking at phospho-AKT and phospho-ERK1/2, where we have the, this shows you the values in the absence of treatment. Patients that had core cuts taken at diagnosis and then an excision after 2 weeks. And you can see if you didn't have this as a control, you'd interpret this as perhaps the most potent kinase inhibitor that's actually been used. Therefore, we need to ensure that those markers that we're measuring are not affected as artifacts in this sort of study. I want to just touch on the validity of the changing Ki67 as an endpoint for non-endocrine treatment. In fact, Sara touched on this as well. We did an analogous study to that which you was talking about there, the palette study, where we looked at letrozole plus or minus palbociclib. And you can see there that the patients that got letrozole plus palbo, both at 2 weeks and then at 3 months, actually had a much more complete suppression of Ki67. However, we now know from the PALICE study that the combination there was no better than letrozole itself or endocrine therapy itself. Therefore, I think we need to be quite careful about extending this to agents which are not endocrine. I'm fairly confident about the hormonal agents. We did also do this study where we looked at lapatinib and the value of Ki67 there. Now, I wouldn't claim that Ki67 is a valid endpoint of efficacy of lapatinib in this circumstance, but what we did show was there was a decrease in Ki67 in the HER2 negative group, not as great, but significant as in the HER2 positive group. And indeed, those that showed the drop in Ki67 all had high HER3 levels, indicating this may be an issue related to the heterodimers. So there's just an opportunity to look at the biology, even if the marker is not valid for long-term prognosis. Just talking about considering pharmacokinetics and pharmacodynamics, I'll just go through this very quickly, but we know that tamoxifen increases estradiol levels massively in premenopausal women. You can get values of 3,000 picomoles per litre or more. Tamoxifen's half-life is 10 days, taking it out to about 7 weeks to get to steady state. But in postmenopausal women, it is so saturating at its 20 milligram dose, it's effectively pharmacodynamically at steady state well within 2 weeks. In the premenopausal situation, that isn't the case because of the competition between estradiol and tamoxifen, and it will take much longer to get to steady state. One can see some evidence for this in the ADAPT trial, which Oleg Kutz was showing in the last session on the late breakers, that there is much less suppression of Ki67 in the premenopausal patients who had 3 weeks of Ki67 than those that had in the postmenopausal group that had 3 weeks of tamoxifen. And then one last comment, and I'll not labor this point. One of the most frequent questions I've been asked in recent years is, can we do a prognostic test, an oncotype or a prosigna, in tumors which have received 2 weeks of endocrine therapy, given that we do these tests on the excision biopsy? And the answer is no, they're not valid. And just for example here, the progesterone receptor features strongly in the oncotype. It also features in the prosigna. High progesterone receptor in an untreated tumor is indicative of a good prognosis. It's weighted in that fashion. You give the patient 2 weeks of aromatase inhibitor, the progesterone receptor falls to low levels, in some patients completely undetectable, which is indicated then and read out by the test as poor prognosis. Yet it's actually showing good endocrine response, probably improved. It's going exactly the wrong way. So they're not valid in those circumstances. If you want to do it on the pre-treatment biopsy, a core cut before surgery. Okay, thank you for that. I'll leave it there.
Thank you very much. So we actually have a comment and a question from a pathologist talking about Ki67. So the comment is that the pathologist wants to reinforce the importance of thorough representation of the tumors by the radiologist at the time of biopsy to minimize the subrepresentation of tumor heterogeneity. So any comments on tumor heterogeneity and the risk of that from a biopsy perspective?
I tell you, the acoustics in here for me are really
My
bad.
apologies.
Can you just repeat that again?
Absolutely. So the pathologist is trying to reinforce the importance of the representation of the tumor that is biopsied to address the issue of heterogeneity, given that you're relying on this Ki67. So any comment on that?
I do think it's an important issue, and you can see the issue particularly about Ki67 in the untreated group. There is variability. I think it's clearly important that you do get the as representative of a biopsy as you can. We've done studies in which we've done numerous biopsies without treatment at the same time to get some sort of ideas of the confidence with any of these biomarkers. And I think that's what you need to do. What I would suggest you don't do, it has been studied in tried in a few studies, is actually to try to get the growing edge, particularly in the excised tumor, and to compare that growing edge Ki67 against a biopsy which went into the center of the tumor. So it needs thought about this, and it is not an absolute measure. There is some clearly tissue heterogeneity, and we need to keep that in mind when we do the studies.
I have a question for you, actually.
I can hear you.
Being the expert, yes, and what do we know about effect of circulating estradiol level during the menstrual cycle and how that relates to Ki67 changes in the tumor? Do we know anything?
I'm thinking back to some very old data from Tony Howell's group where they looked at this, but they were looking in the normal breast at the Ki67. I don't think this has been studied in tumors. I'm really scratching, thinking back to see whether there is you'd have to do this, I think, in a sort of cross-sectional sense. There were some data where, I'm thinking back, Christopher Saunders did some studies of this type and taken core cuts at the time in the luteal phase and core cuts in the follicular phase, and seeing some differences there. I'll get back to you on that, Sarah. I really can't remember it exactly at the moment.
Just one more question. What about gene expression signatures, oncotype DX? Do you have any data regarding the oncotype DX and the menstrual cycle?
Whether it's changed, you say? Well, I was alluding to that in the last slide there with the progesterone receptor levels and that you do get changes. I think the thing that's really interesting is do the sort of thing that Oleg Glutz was doing in the ADAPT trial, where there's a combination of the oncotype which tries to predict the endocrine response from just a basal level of these estrogen-regulated genes with a test such as this changing Ki67, which tests whether they're endocrine responsive. So you're not trying to predict it, you're testing it. So bringing those two together, I think, may give us added value, and we should look at that more.
Thank you. I have another question that has come online, which actually is very interesting, about the role of ovarian function suppression in combination with tamoxifen and aromatase inhibitors in premenopausal women, and is 2 weeks enough for that setting?
So that was exactly what Oleg was showing in the late break-in session there. It's, you have to be quite careful about the ovarian suppression, of course, because if you need to give it enough time for that to have a complete effect. If you want to get immediate ovarian suppression, then using an agonist isn't the way to do it. A GnRH antagonist is good, and the Italian group did a terrific study on that. I wish I'd done that study myself, actually, showing that the change in the LH and FSH drops off within 1 or 2 days there, using Degarelix in that case. Yeah, that's the way to do it. The premenopausal woman is a really complicated situation, but the stuff that Oleg gave, if you didn't see it in the late break-in session, it's worthwhile picking up the slides on that if you're interested.
And then one last question before we move on about how did we measure the Ki67? What kind of testing? Is it done from the whole tumor? Is it hotspots? Is it a median? How do we test the Ki67 itself?
Did you hear that? I didn't hear that from.
How do we test the Ki67? Is it
Hotspot or the whole tumor, or is it a median?
Two
Pathologist is
hotspots or
asking. Yes.
We've always done it in trying to capture the proliferation across the tumor bed rather than just hotspots. I think it depends. If you're looking for it just in terms of prognosis, going for hotspots makes there's some sort of sense there. But doing it in this fashion where you're looking for repeat biopsies, you might easily miss a hotspot if you're doing that. So, and you're just not getting many hotspots across the tumor. Image analysis is the way to go and trying to capture the whole tumor.
Thank you for this fantastic discussion and for these excellent questions. Moving on to the last 20 minutes, our third topic, and we're going to address, are we sequencing too late? And our very first speaker is Dr. Charles Perou from UNC Lineberger Comprehensive Cancer Center in UNC Chapel Hill.
Thank you for coming today. Today I'll be doing, this is a team effort with should have been Fabrice Andre, or Fabrice was unable to make it here, but certainly contributed to the slides and the talk. And Christoph very nicely stepped in with about 2 days' notice. So special thanks to him. And as you can see, we're going to be talking about, are we sequencing too late, or sort of when's the right time to be sequencing? And we're actually going to cover a little bit of sort of what I call gene panel sequencing, but most of the time we'll be focusing on cell-free DNA. So here's my disclosures. Here's the QR code, so you can scan this. And I'll give you a minute to do that. And then here's the question. Molecular disease assessment using ctDNA serves as predictive biomarker of response to treatment. Yes or no? So we're a little more balanced here, certainly than the last two. Oh, it's a close race, right? All right, so here's a little bit of the outline of what Christoph and myself will be covering. So first, again, talk a bit about when and why to sequence, then some of the ctDNA data, and then we'll end with a tougher question about should we use this in routine practice. So, as most of you are aware, sequencing for specific mutations, particularly in the metastatic setting, is now recommended and the standard of care. They've even been put into sort of bins based upon level of evidence, and there was a brand new one last month. And so this list of, I'll call them clinically validated biomarkers with demonstrated clinical utility that are molecular assays for specific gene variants, is well established. And many of these keep moving earlier and earlier in disease treatment. And so, these assays are done on the primary tumor or the metastatic tumor, and an increasing number of these are also done on cell-free DNAs. Of course, one of the most prominent here are estrogen receptor mutations. If you look on the left here, in this comparison of metastatic disease versus early disease, about the, kind of the number one mutation that is more frequent in metastases versus primary, certainly for your positive patients, is the estrogen receptor. As we all know, these are mutations for resistance to endocrine therapy, particularly aromatase inhibitors. There are many hotspots, recurrent mutations that occur, and we know the functional effects of these. And again, this is now well validated and actually clinically actionable. So it's recommended that we perform next generation sequencing on metastatic disease. ESR1 has now achieved SCAT level 1. And for patients, if you can get a biopsy of the tumor, then that's great, and you can perform the assay on that. In many instances, that's maybe not possible, and here's where certainly the utility of ctDNA sequencing can also be used to identify, for example, estrogen receptor mutations. But what about beyond that? How early should we go in disease progression to look for these variants in the presence of ctDNA, and then if we see them, what do we do? So, as many of you know, in the United States and around the world, there are many ctDNA assays of varying sort of molecular biology. Some are general, what I call sort of exon capture, take all the genes. Others are tumor informed. We had a great poster session and many individual talks on this here. Actually, I'll send you to this poster session, which actually they have a number of these newer technologies as well as these sort of more established technologies, and there were some great talks there. So here from this is an interesting study from this PADA-1 study looking at 2 different treatments in ER mutant patients. But one of the things they identified here, and I'm sure many of the audience know, is that the ctDNA can often be detected in patients before the presence of the disease as indicated by other assays such as imaging. So you get this lead time where you may have a patient who's ctDNA positive, but imaging negative, and so what do you do there? And we'll discuss that a bit later in the talk as well. Here's an indication showing those patients in the same study who did not have a drop in ctDNA had a significantly worse outcome than those who had a drop or had no ctDNA. And so here, this clearly can identify a prognostic group of patients. And as was shown in that poster session, and as I'll show you here, the identification of ctDNA in most instances, compared to those who don't have ctDNA, identifies a worse outcome group. Now we're looking at early stage patients, post-neoadjuvant treatment, and those who were ctDNA positive, as I just said, had a worse outcome than those who were negative. If you look specifically right at the residual disease stage setting, again, those with ctDNA did worse than those who were ctDNA negative. And again, I think there's a lot of data sort of showing this prognostic feature. So, I've summarized a little bit of this prognostic feature. I have not shown you the analytic validity of these assays, but many of them have demonstrated strong analytic validity. So then the question is really, what's the clinical utility? I think for prognosis, it's there, but what about beyond that? So here's where I'll turn over to my partner, Christos Sotiriou, who's a professor at the Jules Bordet Institute. And actually, he gets the harder part of the discussion here.
Thank you, Jacques. So I do speak French, but I'm not Fabrice André. So I'll try to convey his thoughts here today with us. There are four actually arguments that I'll try to go through each of those, demonstrate that although there's a superior technique and we are not that yet today to use in clinical practice. Because the four arguments that we would say that are you ready to do that, to use liquid biopsy, is that if early intervention improves outcome, if ctDNA clearance is a surrogate of outcome improvement, for instance, for drug development, if you can decrease treatment burden in patients with ctDNA negative disease, and whether this ctDNA detection allows better access to testing as compared, for instance, to more expensive assays, as for instance, Oncotype. Of course, here in the US, it's not that a problem, but in other countries, it may be a problem, as well as next-generation sequencing. So for the first question, Chuck alluded to the PADA-1 study. So this is a study that patients were treated with an AI together with Palbo, and once we could detect an ESR mutation, patients were randomized to either continue with AI and Palbo, whereas and the other half would be randomized to switch from AI to fulvestrant, because you know that there's a lot of evidence that suggests that once you have this ESR mutation, we did not respond to AI, whereas we can respond to ESR degraders, as for instance, fulvestrant. And that study actually shows that there was a little bit improvement of PFS for those patients who switched to fulvestrant once the mutation was detected, but this is only about 3 months, so 2 months, so it's not that great in order to embrace that in our clinical practice. Another example is in the CTRAC, 10BC, whereas in this study, triple-negative breast cancer without actionable mutations was supposed to receive pembrolizumab, and in this study, actually, very, very few patients were able to get pembrolizumab because when we detected ctDNA DNA in the blood, those patients had already macroscopic metastases, so they were not were excluded from the study because of the very, very short lead time. So to summarize here is that there is no evidence that adding a therapy or changing the therapy at a time of ctDNA detection improve outcome, but there is a hope, and I think we will go there. There is now the SERENA-6 study, or phase 3 study, that interrogate the same design as PADA-1 study with a better drug. And there is ongoing trials in now the luminal space of early detection of circulating tumor DNA and intervention. Now, the second argument is whether ctDNA clearance is a surrogate of outcome improvement. This is very easy because there is no data. There is no data evaluating, whether the drop of ctDNA or clearance correlates with the benefit of a drug regarding patient outcome. There is a better. It doesn't mean that when you clear ctDNA you have a good prognosis. It doesn't mean that it's going to be translated to a difference in PFS. So ideally is to demonstrate that the delta of your drop of ctDNA correspond to the delta that you would see, for instance, in the PFS in a study. And we don't have the data, and also we need to have many patients in order to validate that concept. The third is that can we decrease treatment burden in patients with ctDNA negative diseases who did, for instance, with Oncotype, forgo chemotherapy, where although there is, this is an example, for instance, of patients that after, this is after neoadjuvant, I don't remember that. Yes, after neoadjuvant therapy, the patients who did had circulating tumor DNA, they had much poorer outcomes compared to those without ctDNA. But you can see also that among those without ctDNA detection, their prognosis is not great. I mean, this is better, but there are still patients who recur. So I wouldn't, based on these results, forgo any therapy. So I would like to give something more in order to improve their outcome. And the fourth question is whether ctDNA detection allows better access to testing. This is, we debate a little bit with Fabrice. It would be, of course, great to have a circulating tumor DNA assay that is cheaper and easy to do in the clinic. There are some examples here. This is just looking for tumor fraction. You see, for instance, that you can actually very nicely split that population according to tumor fraction, which is actually easy to do, but it's not ready for the clinic, and I think there's lacking funding in order to move these devices in routine clinical practice. So we'll finish with these conclusions that I think we all agree among us, and Chuck and Fabrice. Clear ctDNA is recommended late in disease course to detect action with alterations, including S1 mutation. As Jack showed, detection of ctDNA early in disease is associated with poor outcome. This is for sure. We have a lot of data now, but the clinical utility is not that yet based on what I just showed to you. With that, thank you very much, and we wait.
Thank you very much. Any questions from the audience for the last two speakers? I had a question. So for the SERENA-6 and the PARA-1 studies, how relevant or important do you think would overall survival be as an endpoint as well? So certainly we are seeing that when you have a decline in ctDNA, you are seeing the benefit of changing treatment and improvement in progression-free survival. Do you think there is going to be an importance to follow through and see if overall survival can be impacted with such an approach?
This is an excellent question, and I think it's a risky study. But we should go and check for that. So I don't have the answer, but it's something that we will see in the future.
Thank you. Yes.
So this is actually in part an answer to the question I was asked in the last session, but it's also relevant to the genomic side of things. So we did do a study with people actually in Vietnam who had an oophorectomy study, but were doing core cup biopsies diagnosis, then 2 weeks later. And of course that then meant that some of them were in the follicular phase, some were in the luteal phase. We didn't look at Ki67 because it was not in context. What we did look at was the expression of estrogen-regulated genes that sit in some of these genomic tests and also some of the proliferation-associated genes. And they do change quite profoundly in some cases. So I think that there is a need to really look at the variability of these tests across the menstrual cycle to see to what extent that might impact on diagnostics.
That's great. Thank you so much for that follow-up. So with that, we'll close this session. Thank you all to the speakers for such a fantastic discussion, for raising all the controversies we face, and hopefully we can keep addressing them in the near future.